Good afternoon, everyone. My name is Natalie Slaughter, and I am the Director of Health Integration at the Association of State and Territorial Health Officials, also known as ASTHO. I would like to welcome you to today's webinar on Pay for Success Financing and Opportunities for Public Health. ASTHO is committed to supporting state and territorial health officials and their leadership teams in reforming models for payment and delivery services within the transforming health system. ASTHO, with support from the Health Resources and Services Administration, is hosting this webinar to provide information to states on opportunities to strengthen their population health activities. Objectives for today's call are 1, describe how Pay for Success financing works. 2, provide an overview of the current landscape and progress states have made in implementing Pay for Success, including those aimed at addressing social determinants of health. And 3, to share challenges, emerging lessons learned, and potential policy reforms to create a supportive environment for Pay for Success. This webinar will have substantial time set aside for discussion among participants and to answer your questions. Participant lines have been muted during the presentation. However, the operator will provide instructions to open the phone lines during the discussion period. You may also submit your questions into the chat box at any time. And now I am pleased to introduce today's speaker, our esteemed guest, Mr. Ian Galloway. Mr. Galloway is a Senior Research Associate and Oregon State Community Development Field Manager at the Federal Reserve Bank of San Francisco. Ian researches and presents regularly on a variety of community development topics, including crowdfunding, investment tax credits, the social determinants of health, impact investing, and Pay for Success financing. He recently co-edited Investing in What Works for America's Communities, a collection of essays jointly published with the Low Income Investment Fund on the future of anti-poverty policy. And he also published the article Using Pay for Success to Increase Investment in the Non-Medical Determinants of Health, published in the November 2014 issue of the Health Affairs Journal. Previously, Ian developed a social enterprise for the Portland, Oregon Homeless Youth Agency called Outside In, and he holds a master's degree in public policy from the University of Chicago. So at this time, I'd like to give a warm welcome to Mr. Galloway and turn the presentation over to you. Thank you.
Thank you, Natalie, and thanks everybody for tuning in today to hear a little bit more about Pay for Success and how it can be used to address the social determinants of health. A lot of what I'll be talking about today is included in that Health Affairs article that Natalie mentioned. I'm happy to send it to you. It's behind a paywall, but just send me an email after this presentation and I can share it with you. My email is on the last slide of this slide deck. Okay, so let's get into this. Can we advance the slide? And I'm sorry, we have to do the slides manually because I'm behind 15 firewalls at the Federal Reserve, so I apologize for that. So this is kind of the big picture of why I think this is a critical issue. Obviously, everybody on the phone is well aware of this challenge. This, of course, is a chart that along the x-axis reflects the cost of providing health care here in the United States. It's substantial relative to our peer countries. And it also doesn't bias a lot of life expectancy, which is, of course, ultimately what we hope that that spending would lead to. So the way I see it is we're not getting particularly good return on our investment with our healthcare spend. Next slide. So, of course, many of you have seen this slide or some variation of this pie chart before. There are many, many things that contribute to the fact that we don't have as long of a life expectancy here in the United States relative to our peer countries. One of them, of course, is the fact that we don't provide adequate health care to everybody, although the ACA significantly addressed that challenge. But there are a number of other circumstances that contribute to premature death, including our behaviors, our genetic predisposition, our social circumstances, and our environmental exposure, along the lines of Flint, Michigan, and the lead in the water there. Next slide. So big picture, though, I think what's important to take away is that a relatively small slice of what contributes to our premature death is related to access to healthcare. And I don't want to minimize the importance of healthcare and having access to quality healthcare, but I do want to emphasize that there are a number of things that have nothing to do with healthcare that contribute to our health. And I think the challenge has been, how do we shift resources into some of those things that address the social and otherwise non-medical determinants of health, so that we're not spending so much money on healthcare and getting such poor results. Next slide. So this is an oversimplification of the problem, but I think it's good sort of grounding for the conversation. So this is kind of how I see our circumstances as it pertains to the social determinants of health. So this is the challenge that we're in today. We have an emergency situation where a number of people require significant healthcare treatment for diseases and conditions that could have otherwise been avoided entirely in the first place or minimized if we had addressed them further upstream, particularly with non-medical investments. But that's not what we've done. So next slide. What we've actually done is the compassionate thing, I think. In many cases, we've built a robust healthcare infrastructure to treat these people and their acute conditions so that they don't end up suffering and don't end up dying, obviously. And the challenge, though, is that by doing that, next slide. The challenge, though, is that by building this robust healthcare infrastructure sort of at the bottom of the hill, so to speak, is that it's cost a significant amount of money. It's caused us to dedicate a significant amount of our resources to the tune of almost, as you guys know, $3 trillion a year annually to healthcare, to the healthcare industry. And that doesn't leave a lot of money left over to invest in the things that would keep us from driving off the road in the first place. So the preventative things, the investments in the non-medical determinants of health, which we know will have a significant impact on health down the road. So that's one significant challenge. Next slide. This is a little bit more nuanced, and this is, I think, the real value of pay for success. There's a funding and financing component to it that's important. But I think the risk mitigation is actually what makes pay for success such an interesting tool for public health. So obviously, we know we need to invest upstream. We know we need to invest in things that keep people from driving off the road in the first place, whether it's speed bumps or signs or better guardrails. But our challenge has been that we don't have a great way of evaluating the effectiveness of those interventions as it pertains to improving downstream health. So if we're asking for hospital systems, or if we're asking for CMS, or if we're asking for coordinated care organizations or ACOs to make investments upstream and in the non-medical determinants of health, they need to have some assurance that those investments will actually translate into reduced healthcare costs, because they will have to cannibalize their healthcare claims budget, their healthcare spending budget, in order to make those investments. And if they find themselves in the same position that they're in today, where they have to pay out to pay for those healthcare needs when they arise, or pay those healthcare claims when they're filed, it puts them in an awkward position, because it discourages those types of investments because of that potential risk that they may not actually translate into downstream reduced healthcare costs. And even if it's a relatively small risk, it's enough to keep a lot of healthcare payers, insurers and others, sort of on the sidelines, even if they understand intellectually that the best way to spend their resources is probably to move them upstream and not wait until people get sick to spend their budget. Next slide. So what is pay for success? So basically, pay for success is two elements. Has two key elements, and the most important one is this first one. I'll talk about the financing component on the next slide, but I think this is really what makes pay for success so interesting, and that is the performance-based contract. And that contract links an end payer, and that end payer is usually a government agency. It doesn't have to be. It could be a health insurance company. It could be a foundation. It could be a wealthy individual. It doesn't matter, as long as that end payer commits to pay for a certain verifiable, measurable social or medical outcome, health outcome. And that end payer engages in a contract with a nonprofit service provider that works in the community and provides a social program. And the nonprofit has to deliver the outcome, however defined in the contract, according to the terms of the contract and on schedule, before the end payer pays for that success. So if the nonprofit fails to deliver the outcome on schedule and according to the terms of the contract, the end payer is off the hook. They do not have to pay for that failure, which is why, of course, we call this pay for success. And it's worth noting that that middle bullet, there's almost always an independent impact auditor included in the transaction to make sure that success, however it's defined, is actually being achieved. And that, of course, adds to the cost, but it, I think, increases the legitimacy of the contract and the end result. Next slide. So obviously, if you think about this from kind of a macro standpoint, this kind of flips the typical social sector funding relationship on its head. Usually when we have a social program that we want to fund, a foundation or government agency will put an RFP out into the world. They'll receive applications from nonprofits to provide the service. They'll select one, and they'll resource that nonprofit immediately. And that nonprofit will then run their program for however long the contract stipulates. And the hope is that the program will produce the outcome that the foundation or funder or government agency wanted in the first place. But they don't have to worry about coming up with the funding to run the program because they've already secured it at the outset of the contract. With Pay for Success, that funding is held in trust until the end of the contract period and is only released if the nonprofit produces the verifiable outcome, which of course creates a cash flow problem for the nonprofit because they need to run their program in order to achieve success and trigger the success payment. So they have a funding gap that needs to be filled. So this is the financing component of Pay for Success. I have to be totally honest with you, this tends to be the most controversial element of Pay for Success. A lot of nonprofit providers and government agencies are uncomfortable with a private sector financing partner fronting the money to these nonprofits, and in particular because there's usually some expectation of a return on that investment if success is achieved according to the terms of the contract. And that relationship is again unconventional, and there are some agencies and there are some nonprofits that are uncomfortable taking on that private sector partner to provide that financing. So just wanted to mention that as something to keep an eye on if this is in fact something you'd like to pursue. So this investor, whoever it is, it could be again a foundation, it could be a wealthy individual, it could be a bank, it could be a pension fund, an endowment of some kind, provides the upfront funding to the nonprofit to run their programming for the duration of the contract. The financing terms, which is to say how much is the money costing the nonprofit, tends to depend upon the difficulty of achieving success. Is this reducing high school dropout rates by 5% or reducing high school dropout rates by 50%? That will obviously change the risk profile of the investment, which changes the investment return expectation for the investor. The track record of the provider, is this a new kid on the block with a great idea, or is this a nonprofit that's been doing this in the community for a long time and has the data to back it up? And the length of the contract. There's a time value of money, and the longer the contract, the more expensive the financing. All of those things affect the terms of the investment. And it's worth underscoring that it's the investor and not the nonprofit typically that is bearing the risk of failure if the nonprofit does not produce the outcome and the success payment is not triggered from the government agency or the end payer, then the investor does not get their money back. So they're the ones that tend to bear the risk of failure, which is why another reason that it's important that they receive some rate of return, because there is real risk associated with this kind of investing. Next slide. So I wanted to walk you through a health example. There aren't a lot in the United States. Otherwise I would have picked a U.S. Example to walk through. But this is an example in Canada that I think is a nice application of Pay for Success and something that could be replicated domestically. This was a Pay for Success initiative that launched recently to address hypertension and specifically to ultimately reduce heart disease and strokes for Canadians. And basically the reason this is so important, and of course this is all very familiar to you on the phone, about half of Canadians over 60 are affected by hypertension, and another quarter of Canadians are over 60 are affected by pre-hypertension. So the goal here is to reduce the number of Canadians experiencing pre-hypertension from ultimately becoming hypertensive and increasing their risk for heart disease and stroke. Next slide, please. The program is limited to Toronto and Vancouver. In order to get their target number of 7,000 program participants, they're going to screen about 29,000 for pre-hypertension. The goal of the whole program is to reduce the average blood pressure of the entire cohort by at least 2 units, by at least 2 points, within 6 months. And the program cost, assuming again a 7,000 person participant rate, is about $3.4 million. That will be less, of course, if they're unable to recruit the maximum number of participants. And the total possible investor return, again assuming that 7,000 participation rate, is $4 million, which allows for a $600,000 return to the investor if, of course, everything is a home run, which translates into about an 8.8% IRR. Next slide, please. So the way this is going to work on an individual basis is a program participant will receive a blood pressure measurement from a volunteer employed by the Heart and Stroke Foundation, which is the project manager for this project. If they are determined to be pre-hypertensive, then they will be placed in the program and they'll be given some support about lifestyle changes, including diet and exercise, and the volunteer will help them set goals to achieve those. And the participant will also be enrolled in an online platform that does a number of things, connects them to a community of people similar to them, has built-in incentives to encourage behavior change, and connects them to community activities nearby so that they can take advantage of those. And then after 6 months, the platform will actually prompt the participant to come back to the volunteer to get their blood pressure measured again. And the program will end with some additional advice to sustain the lifestyle changes that have been made. And just kind of to back up to the slide talking about the risk of investing upstream, I would say that it's the online platform and the advice that the volunteer is providing to change exercise and diet habits that would constitute the risky element of this project. And I think all of this seems common sense to us, and I suspect it's going to be wildly successful, but we don't know. And frankly, the online platform may not be the right solution for this group of people, even though at the outset it seems completely reasonable. And so that's the risk element here that we're trying to mitigate, is we're trying to try things that may or may not work, that we suspect will work, but if they don't, obviously have a significant consequence in terms of downstream increases in heart disease and strokes. So this is the risk component that we're really trying to address with Pay for Success, and it's just important to keep an eye on that. Next slide, please. So these are the participants, the parties involved in the contract. As I mentioned before, the Heart and Stroke Foundation is kind of the program manager for the deal. They coordinated it, they developed it. They will be ultimately held responsible for whether the project comes together the way that it's intended to. The Public Health Agency of Canada is going to be the end payer in this transaction. And the Mars Center for Impact Investing is responsible for recruiting the investment partners. There are 10 investors who funded this project up front. There was a law firm involved that wrote the contracts, and the Social Research and Demonstration Corporation will independently validate the results. That's that independent impact auditor that I mentioned previously. Next slide, please. So this is, I'm sorry for this slide, but I think it's important that you see the project structure visually so you get a sense of how the money flows. So as I mentioned before, these projects begin with a contract between an end payer and a nonprofit provider. In this case, the nonprofit provider is the Heart and Stroke Foundation, and the end payer is the Public Health Agency of Canada. There is a project board that advises the Heart and Stroke Foundation throughout the process. That's why I included them here. But they're not a necessary element in this initial contract. It's really more important to focus on the performance-based contract between the Heart and Stroke Foundation and the Public Health Agency of Canada. Next slide. So once that contract is in place and we have a sense of what the end payer is willing to pay for success and what success means and how it's going to be measured, the project lead, which again in this case is the Heart and Stroke Foundation, is able to reach out to investors to provide the upfront funding that it will need to provide the services that hopefully will produce the end result that will trigger the success payment. So once that investment capital is secured, next slide, the Heart and Stroke Foundation is able to again recruit participants in the program and provide services to those pre-hypertensive people. After 6 months, next slide, SRDC will come in and evaluate whether or not that cohort of people was positively affected by the intervention and to what degree. And they will communicate that information back to the Public Health Agency of Canada, which will make success payments based on that information back to the Heart and Stroke Foundation, who will finally make, next slide, success payments back to the investors that fronted the money to pay for the intervention that ultimately led to the success payments being made. So this is a boilerplate pay-for-success project structure. Just about any PFS deal that you see will look somewhat like this. And again, it's important just to recognize the key parties involved, some kind of contract manager sort of at the center of the project, the service provider, signing a contract with an end payer, in this case it's the Public Health Agency, investors fronting the money and taking the risk on the program being provided with that funding, an independent impact auditor evaluating the success of that program, which then triggers success payments or not, which flow usually back through the nonprofit and then ultimately to the investor that took the risk and made the investment. Next slide. So in this case, success was defined in two ways, and one is sort of a more traditional output, and the other is more of an outcome. And the first is the intake volume metric, and that's essentially how effective were they in recruiting participants to the study, and that will trigger a pre-negotiated set reimbursement rate, depending upon the number of people that they can ultimately recruit. And then the latter, the blood pressure metric, is really the outcome that's most important, and that will be based on how effectively the intervention reduced blood pressure across the entire cohort after 6 months. Next slide. So the way that they're, and by the way, I'm happy to share these slides. I understand that I'm sort of throwing a lot of information at you in a short period of time. So happy to share these, and I suspect Natalie and Anna are as well. Again, just shoot me an email after this presentation, and I can send you my slide deck. But the way they're thinking about this is essentially in 4 scenarios. And that really pertains to that latter success measure, whether or not they actually reduced blood pressure for this cohort. But next slide. But before we get to that, that first measure of success, that output, how effective were they at actually recruiting people to the study, that translates into a basic repayment rate of $230 per person that gets enrolled, up to $7,000, which, doing a quick math, translates into $1.6 million if they max out the program participation rate. If they fail to get at least 1,000 people in the study, I believe that payment rate actually gets cut in half. So there's a significant incentive for them to get above 1,000, and then they will be paid for every person above that at a $230 rate up into $7,000. So that's that output payment schedule. The outcome payment schedule, which I think is the more interesting component, again has sort of 4 scenarios. So the first scenario is that this program is enormously successful and actually not only slows the rise of blood pressure for these pre-hypertensive people, but reduces it. And if that's the case, the public health agency, the end payer, will pay $2.4 million for that success. And that again is if they can reduce the entire cohort average by at least 2 points or more. And just as a reminder, the total potential payment that the public health agency is willing to make is $4 million, and the way we get to that $4 million is adding that 2.4 to the 1.6, and that is the maximum potential return to the investors that funded the program. So that's the home run scenario. Scenario 2 is no change at all. So had this intervention not occurred, theoretically, this cohort would have seen a gradual rise in their blood pressure. In this scenario, that rise has been interrupted. So it hasn't decreased, but it also hasn't increased, which of course is a significant improvement over that scenario. If that occurs, the success payment will be slightly lower than if they had reduced blood pressure, $2.25 million, which is still a significant payment. Scenario 3 is blood pressure continues to rise, but at a slower rate than it would have absent the intervention, and that's compared to a historical baseline. And we can talk about in the Q&A when it's appropriate to use a historical baseline and when it's more appropriate to use a randomized control trial or something a little bit fancier on the evaluation side. In this case, they decided that there was enough research in place that they had a lot of confidence in the historical baseline and didn't need to do a randomized control trial. So in this case, scenario 3, if blood pressure goes up slightly but at a lower rate than it otherwise should have, it triggers a $1.75 million payment. And then finally, scenario 4, nothing happens, the program doesn't work, blood pressure rises on schedule. In that scenario, the public health agency is off the hook and doesn't have to make any payments because there was no success in that case. So this is the payment schedule for this particular project. I like the fact that there are different levels of outcomes that trigger different levels of payments. Not all pay-for-success projects are structured that way. Sometimes it's all or nothing. And I think that can scare away the nonprofit because the stakes are so high, and it can also scare away investors because obviously hitting the home run, even if it triggered a significant payment, is less likely than perhaps a slightly less successful scenario that is still successful, which would potentially trigger a lower payment. So I like the fact that this is a graduated scale tied to different levels of outcomes, and I think that's a best practice in the field. Next slide. So as I mentioned, there have not been a lot of health-related pay-for-success projects in the country. Most of them have gone after recidivism, early childhood education, to some extent home visiting, and foster care. I suspect that there are going to be a number of additional health-related pay-for-success projects in the next year or two. There are several dozen. I've heard a number of estimates in the ballpark of 50 to 60 projects in the pipeline nationwide that hopefully will come online, or some fraction will come online in the next year or two. And I know the folks at HHS are very keen on seeing something like this happen. And so I suspect the composition of projects will change pretty dramatically here pretty soon. But it's still relatively new. I mean, we and this is a bit out of date. There was a flurry of activity before the end of the year that is not reflected on this slide. But you can see it's still a relatively small number of projects overall, and not a lot of states. You have New York State, Massachusetts, and Connecticut, mostly counties, and to some extent cities that are doing this. And there's probably a lot of reasons for that. I think state budget decisions obviously can be more challenging than a smaller county operation. But there's no reason why a state couldn't participate in a project like this. So next slide. So I give a version of this presentation to a lot of different audiences. I get a lot of very similar questions, and I like to end with a few of them just to get out in front of it. And I'll just quickly go down the list and just share my perspective on these questions, which I'm happy to discuss in more depth in the Q&A. But the reason the government doesn't pay for these programs directly is that risk challenge, and also that funding challenge. We have a funding issue today because we've built out, again, that robust healthcare infrastructure, and that's keeping us from making the investments upstream that we otherwise would. Will this privatize the social safety net? This is, I think, an interesting question. The truth is that the social safety net was privatized a long time ago. Most social services are provided by nonprofits and not the government directly. The only change here is that we're changing the way that we're paying those nonprofits. Instead of paying nonprofits at the outset to run a program that we hope will produce an outcome that we want, we are withholding those funds until the outcome is achieved and only releasing them then. So this doesn't privatize the safety net any more than it already is. It just changes, again, the way that the funding flows. This is a question I get a lot about a Wall Street takeover. Again, this goes to some people's discomfort with a private sector financial partner coming from the community development financial side of things, which mostly revolves around affordable housing and community facilities development. Private sector financing has been a critical component to all of those things. And obviously, all of these contracts need to be carefully constructed so that the investors aren't in a position to take advantage of the nonprofit or the government agency involved. But that's very doable. So I don't think this is handing over the keys to Wall Street. I think this is creating investable opportunities in impactful projects that will be attractive to a number of different financial partners. Some of them will be Wall Street banks, and others will be community banks and community foundations. So I'm not as concerned about that issue. Fraud and abuse is a very legitimate issue. Whenever you set a target and attach significant financial and funding to it, resources to it, you're going to create an incentive for folks to cheat and for folks to skim and otherwise take advantage of the program. So this is just a reminder that when you draft these contracts, be very, very careful about what you put in them and what's allowed and what's not allowed. The worst thing that we can do is write a contract that doesn't plan for all the contingencies down the road, and you find yourself in a litigious circumstance when one of the parties involved goes outside of the contract and there's not a clear recourse to deal with it. So fraud and abuse is something to always keep in the back of your mind. Small providers honestly will not be particularly well suited for this. These projects tend to be large, so the magnitude of millions, if not tens of millions. It's very difficult to engage smaller providers who are unable to scale to the degree necessary to justify the transaction costs associated with putting these projects together. And I think that will change over time. I think there's an opportunity for larger nonprofits to subcontract with smaller nonprofits, but today this is really only an appropriate place for larger, high-capacity nonprofits to participate. And then the last one I think is an important one to end on. I think looking at the entire field, we've made a mistake of equating cost savings to the system with value created, and I think that's not the right way to look at it. I think the better way to look at these projects is, what is it worth to us to reduce the number of people who experience heart attacks and strokes, for example, using the Canadian example, and assign a value to that, independent of what that will save the healthcare system. And it could be that the value is vastly more than the cost savings, and it would be unfortunate if we capped our willingness to make success payments based on our estimated cost savings to the system, because that will, I think, lead to a lot of good projects not being funded that would have otherwise generated significant value to society. So that's my presentation. Again, that's my contact information there. Please feel free to send me an email after this presentation if you have any additional questions, or if you'd like me to share the slide deck or my health affairs article, but I'm happy to take questions at this point.
Great. Thank you very much for that very informative and thoughtful presentation, Ian. We will now ask the operator to open the lines for questions. And just a reminder, if you do have a question, you can feel free to submit that through the chat box located on your screen. And the operator will also give us instructions in a moment on how to unmute your phone line if you do want to ask questions over the phone.
And if you have a phone question, please press *1 on your telephone keypad. Again, that's *1. At this time, there are no phone questions. Actually, now you do have one. Hold one moment. Caller, please announce yourself.
My name is Mehran Masoudi.
Okay.
Go ahead with your question.
Okay, great. Thank you. I'm the Regional Health Administrator with HHS in Region 6 based in Dallas, and thank you very much for your presentation, very informative. I had a question related to the scenarios that you discussed, and in particular, much of the work here and the success of it rests on the foundation and ensuring that the volunteers and the work that is being done, as you said, is the risky part. It's mostly contingent on ensuring that that work actually gets done. Will there be any support provided, say, from in the scenario from Health Canada in trying to come up with best practices or some lessons learned from the past to provide these foundations and thus ensure, making the investors feel a little bit more comfortable that these folks are going into this with as much armament, so to speak, available to them? Thank you.
Sure. No, thank you for that question. And I have to say that I'm not an expert in this particular project. I have a general sense of how it came together, so I don't want to misspeak. But I will tell you that this project is an iterative one. There was a previous hypertension intervention that the Public Health Agency was funding directly that didn't have some of these elements, that was successful, I think, but not as successful as they wanted it to be. So I think the risk to your question about whether or not there were some assurances in place that this had a reasonable chance of succeeding, I think the theory was that because this is an iteration of a program that was reasonably successful in the past, that that gave everybody a reasonable amount of assurance that it wasn't going to be an abject failure. But there is still that risky element, and I'm not sure if it's the online platform that is the new addition to the equation. But there is risk in this transaction. If there wasn't, then the Public Health Agency, I think, would have funded it directly, which is, of course, what we tend to do right now. So I think everybody acknowledges that there is a part of this that we can't predict, even if most of it is something that we're very comfortable with because we've done it before. So I think actually this is a nice hybrid of the two. It's not coming up with a new program to solve an impossible problem that we have no basis for assuming whether or not it will be successful or not, and then crossing your fingers and hoping for the best. This is really, hey, we've got a good program, a solid program now. If we added a few more bells and whistles that maybe aren't as well tested, then maybe it could be a great program. And so let's build a pay-for-success contract that encourages that iterative improvement and allows us to sort of deal with that risk when, if we didn't have that, maybe we would shy away from experimenting with some of those bells and whistles and stick with the proven program that may not be as effective as it could be with these additions. So I would say that that's how they dealt with some of those initial concerns about the efficacy of the intervention.
Ian, we do have a few questions that came through the chat box, and I want to just insert one right now, one from Brendan Brown. Question is that, do you think that rising interest rates will price out the ability to launch public health pay-for-success projects? And I think in that same vein, Ian, if you can even speak to the political climate maybe for pay-for-success or the support around pay-for-success, that would be helpful.
Sure, and I appreciate both of those questions, and I have to caution. We get into tricky territory with both. I obviously can't comment on interest rates rising or falling per se. I can talk about hypothetically if interest rates did go up, what effect would that have, which I'm happy to do. And in terms of the changing political climate, again, I can't comment on that beyond sort of the hypotheticals. So I'll do my best to answer both questions with those two caveats in mind. In terms of rising interest rates, I think that obviously when interest rates rise or fall, it affects all types of investments, because if one investment becomes less or more expensive, then it incentivizes you to choose one over the other, and rising interest rates will change the investment profiles for all types of investments. So in terms of pay for success, if, for example, a bank's cost of capital were to go up, which would be the case if interest rates rose, then they would expect a higher rate of return for this kind of project. I don't honestly think that's the driving factor right now. I think honestly, I think most of these deals are already underpriced, which is to say that investors should be charging higher rates of return to reflect the real risk. I think a lot of investors have been happy to cap their investment potential because there are PR benefits to participating in these projects. There are Community Reinvestment Act, CRA, which is sort of the regulatory obligation for banks to invest in low-income places. Those kinds of incentives. Foundations, of course, don't need a market rate of return on their investments if they're program-related investments. So all of that translates into a relatively low expectations of return, I think, compared to what the market would truly charge. Because in a lot of these cases, you're taking a bet on a nonprofit to produce an outcome in the future that may or may not present itself. And in many cases, it's an all or nothing proposition, and that's real risk. And not to get too wonky on the financing side, but basically we're talking about equity risk, so investing in a small business, for example, and debt-like returns, so more of a fixed income return profile. So low return rates, high risk, and that's backwards, obviously. So I think that's what needs to change, and I think rising or falling interest rates will have a marginal effect on the net equation. I think the bigger issue is how investors will change how they price the risk. That's going to be the bigger driver in terms of the rate of return. And in terms of the political climate, I would say that Pay for Success is relatively bipartisan, and you see that actually with Pay for Success legislation in the previous Congress. And I think the reason for that is twofold. One, it increases funding for good evidence-based nonprofits, which tends to appeal to progressives. But it also infuses a little bit more market discipline, a little bit more public-private partnership, which I think appeals to conservatives. So I think it's a nice balance politically. And it's analogous to, I would say, the low-income housing tax credit, which is an $8 billion a year federal program that basically funds almost all multifamily affordable housing development across the country. It's not well known, but it's been very resilient politically because it has the same elements. It has a public-private component. It has a compliance component, evidence-based component, but it also increases funding for affordable housing. So I think Pay for Success will follow a similar, hopefully a similar trajectory and get bipartisan support going forward.
So at this time, I just want to check to see if there are any questions on the line.
There are no further phone questions.
Okay. So, Ian, there's another question that's come through the chat box, and this is regarding sustainability, and specifically how do programs that are demonstrated as successful use this funding approach? Let me back up. How do programs that have been demonstrated as successful through the Pay for Success initiative, how do they use this funding approach and continue after it's over to sustain their program? What happens when the funding has ended, and how do they sustain their programs from there?
Yeah, that's a really interesting question. We don't have a great answer for it because none of these projects have actually been completed, successfully completed. So we don't actually know what is going to happen. There are a few scenarios that I can think of off the top of my head. One is that this project, if it was very successful, lifts this nonprofit up as a leader in that particular field, and the government agency that they were contracting with for the Pay for Success project then contracts directly with that nonprofit going forward because they have a high degree of confidence that nonprofit is producing the outcomes that they care about. So that's one scenario. There's not to be cynical about it, but there's probably going to be instances where these are one and done projects. The project succeeds. Everybody agrees that it was the right thing to do, but the political environment has changed in that particular jurisdiction, and maybe the leadership has changed, and there's less interest in doing another one or supporting that particular approach to solving that particular social problem. I hope that's not the case, but I suspect it will happen. And then there's the other alternative, which I'm partial to, and I acknowledge that it's more expensive and potentially a lot more headache, but I think the benefits outweigh the costs, and that is that we sort of do this in perpetuity. And my reason for thinking that is, a lot of the programs that we fund now that don't necessarily work used to work. There's a reason that we started funding them 10, 20, 30 years ago, and the problem has been that we don't typically have a built-in performance feedback loop. So we don't have a great ability to do ongoing program evaluation as it pertains to outcomes. We're pretty good about it as it pertains to process. Are you checking the boxes? Are you following the recipe? But we don't have a lot of confidence that it's producing the outcome that we really want, even if it used to. And so my concern is if we do this once and then we go back to a conventional contracting approach, then in 10, 20, 30 years, we're going to be funding a bunch of programs that we don't have much certainty are actually producing the outcomes that we care about anymore. So I hope we don't go down that path. And the fourth scenario, which is maybe a little bit of a hybrid, is that some of these projects actually have nonprofit skin in the game. So if the nonprofit, actually I'll give you a specific example. There's a permanent supportive housing project in Santa Clara County in California that was put together by Third Sector Capital Partners, which is a national intermediary. There are a few of these, and I would encourage anybody interested in this kind of contracting to reach out to one of them. Social Finance US is another excellent national intermediary. There's a number of advisory services, the Sorensen Center at the University of Utah, Urban Institute, the SIB Lab at the Kennedy School at Harvard. There's a number of these intermediaries. Nonprofit Finance Fund is another that can help you put these deals together. And in this case, it was a Third Sector Capital Partners project to reduce the number of people living on the streets chronically. And in this case, the investors fronted the money to pay for the supportive housing, and they will be paid back based on whether or not those people stay in the supportive housing for a long period of time. So there are benchmarks, and if they hit the benchmarks, and the longer those people stay in the housing, the more money the investors get back. But what's interesting about this project, as it pertains to that question, is once the principal investment is repaid, so once the money that went into the project has been fully repaid to the investors, I believe plus a base interest rate, then from that moment on, all of the success payments that are made are actually shared between the investors and the nonprofit. So the nonprofit has a huge incentive to get over that threshold, to get the investors fully repaid, because at that moment, every additional success payment that's made contributes to their bottom line. And the reason I mention that is because it's a nice way to eventually get to sustainability, because if they can bank those payments, then the next time around, they won't need to borrow as much money because they'll have more money on hand that can be used to fund the program. And they won't have to rely on investors as much. Or they could do a bigger project because they now have more resources. So I think that's a nice way to structure these, and a nice compromise between what investors need and what is good for the nonprofit. So to me, that is a best practice that's worth looking at if you're going to do a project like this.
At this time, are there any additional questions from the phone?
Not at this time.
Okay, I think we will just have one final question, and then we will close because we are coming to the top of the hour. So just one final question for you. If an entity was interested in Pay for Success, where would they start? And how do they even evaluate if this is something for them?
Yeah, that's such a great question. And the truth is that all of these projects so far have come together differently. So I'm not sure there's a consensus answer to that question, but just to give you a few examples of what you could do. Let's say you're a nonprofit, and you know you have an evidence-based program, and you're tired of frankly, contracting with government and contracting with foundations on a cost reimbursement basis, because you know that you are producing enormous value to the criminal justice system, for example, or the healthcare system. In that case, the best thing that you can do is compile data. So you need to be able to walk into a public health officer's office with believable data that you can reliably produce an outcome that is valuable to them. So having that initial data, convincing data, is a great first start. And then you can start shopping this concept around to potential partners. If you're a government agency, maybe you have a few areas where you know that your agency or the agencies that you work with aren't getting the job done for whatever reason. Maybe it's existing challenges associated with contracting or procurement or who knows. So you have these hotspot areas where you know you're not getting the results that you want. In that case, I think it's important that you start with a clear identification of what it is that you want. So I was having in a meeting yesterday, talking to a county employee here in Portland, and we were talking about a potential Pay for Success project that would deliver reductions in toxic stress for kids 0 to 5 and kindergarten readiness, and that's what the county is going to focus on because that's what's important to them. So I would say that if you're coming from a government standpoint, being very clear about what you want, what outcomes you want, not the process, not the best practices that get you there, but what you actually want to achieve, and then to the extent that you can estimate what that's worth to you, what you'd be willing to pay for reductions in toxic stress associated with low-income kids, that would be very helpful too. But I would say that's pretty much where you start. In many cases, there is an investor champion, at least with the early projects, an impact investor who wants to invest and spend their philanthropic money differently, and they're working behind the scenes to organize some of these conversations. So it can be helpful to have a third party in the community with some credibility to encourage nonprofits and government partners to at least look at this and consider it. And once that initial phase is done, you typically do a feasibility study, which is a more in-depth analysis of whether or not this makes sense, whether it pencils, what it would cost, what's the scale. And then once that's in place, you move to contract structuring, which actually involves all of those parties sitting down and agreeing to the terms of the contract, the length of the contract, what are we paying for success, who's going to measure it, how are we defining it, all those specifics that are so important. But again, these deals have come together very differently depending upon circumstances. But almost in every case, the best thing that you can do is be clear about the outcome that you're achieving or trying to achieve, and collect as much data and information to back that up as you can, because that's what is going to get these conversations started in most cases.
Great. Thank you, Ian. At this time, we will end the Q&A portion of our webinar. If you have any follow-up questions, please use the contact information on the screen, and we will ensure that Mr. Galloway and our appropriate staff at ASTHO receive your questions. These slides and a recording of this call will be shared with participants at the conclusion of the call, and we will also post the recording on ASTHO's website at astho.org. So we hope that you will use this webinar as a resource, and we'll share this information with others once it's available. We thank you again for joining us today, and I would like to especially thank HRSA for sponsoring this call, and also give Mr. Ian Galloway a special thank you for your time and your information and presentation. Thank you, everyone. Enjoy the rest of your day.
This concludes today's conference call. You may now disconnect.